All right, I'd like to introduce Dr. Pockros to discuss the hepatitis C abstracts that were presented at this year's meeting. And hepatitis C obviously was always one of the larger areas of discussion and topics at AASLD. And one year, Dr. Pockros actually, I believe, gave the hepatitis C wrap-up session at the meeting. And it's interesting that there were, of course, fewer abstracts, I think, this year, and the types of abstracts, the attention has shifted, I think, and I think Dr. Pockros will share that with us. So with that as an introduction, I ask Paul to come to the podium and teach us about hepatitis C at this year's meeting. Paul?
Great, thanks. Thanks, John. Normally at this time I say thank you to the organizers for the invitation, but the organizers made the mistake of inviting me to be a co-chairman, so they didn't have a choice. So I'm going to talk about the AASLD abstracts, and just to preface this, mic's not on. That's it? Okay. So I'm going to start with just going to go over the HCV abstracts for this meeting. I'll start and talk about elimination quickly about persons who use injection drugs. I'll talk about the possibility of a vaccine for Hep C, which we've been waiting for a long time. And then I'll review indications for children, which are now labeled, post-SVR outcomes, which has been an issue, the use of seropositive donors you heard about already from Alex's talk, so I'll just brush over that, and regression of cirrhosis, and post-SVR, which is an area I've been interested in for a while. And then in the last 2 minutes, I'm going to talk about the Simplified AASLD guidelines that just came out, because you might have missed those. They just came out last month. And then recent updates to the labels. Okay, so let's talk about reinfection. So this has been an issue in persons who use drugs for many years, because the argument has been we shouldn't treat them because they're just going to get reinfected. And you can actually use techniques of genotyping and polymorphism, specific polymorphism testing to determine if somebody's been reinfected with a new virus or they have the same virus. So we've been able to sort that part out. So this was a large study from British Columbia where they looked at 5,700 patients, and they had 64 reinfections. So they were actually able to give a number to this, and they found that the reinfection rate in the overall population was 1.2 per person years, but it was twice that, 2.4 in the IV drug users. So you can see there was indeed a higher risk of reinfection. This was directly related to whether or not they were using opioid agonist therapy. So if they were on substitution therapy, they did not get reinfected. On the other hand, if they weren't on substitution therapy, they did. So the conclusion was, okay, you can treat this population. They should be on opioid agonist replacement therapy. We don't see a lot of these patients in our center anymore, but this is who's left, really, that's untreated with Hep C. There's a lot of PWIDs in the United States that have Hep C. Now, what about vaccine? This has been an issue for a long time. And we still have patients ask us if there's a Hep C vaccine. So this was a double-blind, randomized, placebo-controlled phase 1-2 trial of a chimpanzee-derived adenovirus vaccine that was boosted with a modified vaccinia virus Ankara, which is the same boost that they use in the influenza immunization that we all received this year. And this was given to IV drug users. So they monitored a bunch of these patients. They gave half of them placebo, half of them got vaccine. They monitored them for almost 2 years, and the incidence of Hep C infection in the two groups was exactly the same. So it didn't work. However, you can see it did blunt the peak RNA titers, so they were about 5-fold lower in those patients that had vaccination. So they did have an immune response. This was mostly interferon gamma proteins that were elicited by the infection, but it did not prevent them from getting the infection. So we've got more work to do. Now, what about children? Most of you don't probably treat children, but there are over 3 million people, children in the world that have Hep C. These are the countries where it's prevalent. United States, you can see we have a problem, about 20 to 70,000 people infected. Other parts of the world, you can see China has the most. So we now have two labeled indications for children. The first is with GP or MAVRIT, which I'm not supposed to say, but I'm going to say it anyway because people always ask when you say GP, soft valve, what the hell is that? And you say, well, it's MAVRIT and Flus, and they go, why didn't you say so? So, okay, so that's what it is. And this is looking at 3 cohorts, different age groups and weight groups. So they did this by weight. And you have to be a certain age, 45 kilograms or age 10 in order to get the drug right now. But this works in children. They only had 81 children, but it was 8 weeks in everybody, and it was all genotypes. So that works, and soft-vel also works. So this was looking at 200 children. Notice that the younger kids received a different formulation. This was 200 milligrams of sofosbuvir and 50 milligrams of velpatasvir, so they had to make a different formulation for children that were younger. That's half the dose of adults. And adults received the normal standard adult dose. I mean, the older kids did, 12 to 17. And you can see the SVR rates were quite high. You had one non-responder here, you had one relapser here, and in children this young, you don't know what the compliance is, so a non-responder might have just been a child that wasn't able to take the drug. So we have safe and effective pan-genotypic regimens now for children down to age 3. Now, while I'm on the topic, I'll update you on the cirrhosis data from GP, which is MAVRIT. So we've heard this before. Bob Brown presented this data. It's been published now, looking at 8 weeks in compensated cirrhosis. And the data that had been released before was in all genotypes except genotype 3. And it showed that it worked fine and that you could get by with 8 weeks for compensated cirrhosis. Then the genotype 3 data was presented at this year's AASLD. This was the result. So we worried about this population because we thought that those with these pre-existing polymorphisms, the Y93H or the A30K, would need a longer duration. But it turned out they did just as well as everyone else, so they all achieved an SVR12. There was one relapser in the whole study. So the FDA has now approved 8 weeks of labeling for compensated cirrhosis, all genotypes for this drug. So that's pretty simple. Now let's talk about post-SVR outcomes because I think this is an important topic. So if you remember, the Cochrane analysis that was published a few years ago said that an SVR achieved with DAA therapy does not change outcome, doesn't change liver-related outcome, doesn't change mortality. And that received a lot of criticism, but you have to remember the Cochrane analysis is done in a very conservative way based on peer-reviewed, what they consider acceptable, either randomized controlled trials or cohort trials that look at large numbers of patients and are published. And there wasn't enough data. So now there will be. This data was from the archives cohort. It was presented at AASLD. It's not yet published, but it probably will get published in a big medicine paper like JAMA or Annals or New England Journal of Medicine, something like that, because it looked at a large number of patients, 37,000 treated, 24,000 untreated. They had 8,000 deaths, so they followed these patients for a long time, and about 40% were liver-related deaths. So they were able to show clearly that the treated arm had half the number of liver-related deaths as the untreated arm, and those that achieved an SVR had tenfold lower liver-related deaths as those that did not achieve an SVR. And this applied to both PEG-RIBA and DAA therapy, but more so with DAA therapy. So I think that's very convincing data, and when it gets published, the next time there's a Cochrane analysis, hopefully they'll get it right. Now, on the same token, at this meeting, there was good data looking at other causes of death: acute coronary syndrome, end-stage renal disease, ischemic stroke. And all of these were lower in the patients that were treated. Whether they were treated with interferon ribavirin or DAA therapy, they were reduced. We knew this already for end-stage renal disease, but stroke and acute coronary syndromes were lower. So this is relevant because I have a number of patients, mostly female, who are older, who show up and have had Hep C for 40 or 50 years, and they have no fibrosis on FibroScan or mild fibrosis, and they want to know if they should be treated. And I think this data was fairly convincing they should be treated. And interestingly, when you dove down and looked at this, if you look at this forest plot of this population, one is of course, if you cross one, you haven't proven benefit, but if you're on this side of the hazard ratio, you've got a lower hazard ratio, and the orange bars are females. So females tended to get more advantage from DAA therapy, not clear why, but they had lower incidence of stroke, end-stage renal disease, and coronary disease. So I think that's a reason to treat them. And I tell them that, and it's a large study, 16,000 patients, hadn't been published yet, but probably will be, and I think that's a pretty compelling reason to treat people, even if they don't have a higher incidence of liver disease. Now, what about people with liver cancer? This was a controversial issue. This was from the target group. So Carrie Frenette from our center was a participant in this trial, and they treated patients that had HCV-associated liver cancer. And they clearly showed their all-cause mortality was reduced over 5 years, and their liver-related mortality was reduced over 5 years. So I think this lays to rest this issue, and we do treat, Carrie treats these patients primarily because she runs the Center of Excellence for liver cancer, but they all get treated for their Hep C. Now, I'll talk briefly about seropositive donors. Alex already showed you this abstract, so I'm not going to spend time on it, but it clearly shows that you can give HCV-positive liver donors to HCV-negative recipients. So this study looked at kidney transplants, and what they did was they gave the first dose of GP or Mavorite 3 hours before the surgery, and then they gave 4 weeks of Mavorite. 5 of the 10 patients never developed a positive HCV RNA at all. And by the way, if you look at kidney transplant recipients, that's not that unusual. So you can put a positive donor into a negative kidney recipient, and they don't necessarily get hepatitis C. But in this case, half of them didn't, and the half that did all cleared virus in 4 weeks. Everybody achieved an SVR. So it looks like preemptive therapy, if you're going to do a kidney transplant, is the way to go. There was another study similar that Jordan Feld presented, and this really took cojones, in my opinion, because they only treated for a week. And they gave Zetia at the same time as GP. Why would they give Zetia? Who knows? So it's an entry. So what is Zetia? It's an LDL receptor blocker for cholesterol, but it's also the entry inhibitor for Hep C, correct. So that's the Hep C virus uses the LDL receptor to enter the hepatocytes. So their thinking was that they would prevent new hepatocytes from being infected. Nobody's ever proven that, but it was a clever idea. But they gave that and GP for a week, and these were not liver transplants, 12 lungs, 8 kidneys, 1 kidney pancreas, 4 hearts, and everybody was cured. So and they didn't have SVR12 data on all the patients. They had SVR6 and SVR4 on a few of them, but looks pretty compelling. So it looks like preemptive therapy is the way to go, and whether or not you add Zetia, I think, is debatable. Now, what about regression of cirrhosis post-SVR? This is an area we've been interested in. So Gilead has collected a registry. If you remember, they had the SOLAR 3 and SOLAR 4 studies where they gave soft-base regimens to a large number of patients with advanced fibrosis or cirrhosis. And so they've had the opportunity to follow that cohort for many years. And they have data, and they did liver stiffness on these patients after they were cured. And they also did ELF scoring, which you heard about already from Mason, that's going to get likely approved in the United States for NASH, but you could use it for anything. And what they found was that about 50% of the F3s improved their liver stiffness, and about 30% of the cirrhotics improved their liver stiffness over this period of time. And when you used ELF score, it was similar, maybe a little more of the F4s improved their stiffness. Now, there was another study from Egypt that looked at a much larger number of patients, 2,300 patients. And these patients all had paired liver fibrosis assessments, mostly by FibroScan. And these were the F3s right here, this bar, and these were the F4s. And you can see about half the patients in both groups either regressed or reversed their fibrosis. And the others either didn't change or a few of them got worse. But this is a very large number of patients, so it's pretty compelling that if you use FibroScan, they improve. Now, we've been interested in this topic, and Jason Pan from our center published this last year in a smaller number of patients, but the modeling we came up with was that over this period of time, if you use FibroScan, this many people would improve, either F3 or F4 would improve their fibrosis, and eventually everybody would over time. But we then biopsied 15 of these patients, so we convinced to have a liver biopsy, which is not easy to do because once you're cured 3 years, nobody wants to have a liver biopsy. Can't blame them. And unfortunately, a number of the people that had low scores on liver stiffness still had F3 or F4 on liver biopsy. And that was concerning because it suggests that we were overestimating the amount of reversal using liver stiffness. So this was addressed by an abstract at the meeting from a transplant center in Texas where they had protocol liver biopsies. So if you remember, after transplant, regardless of the indication, many centers still do liver biopsies 1 year, 2 years, 3 years, et cetera, after transplant. So they had that data in these SVR patients who had advanced fibrosis before they were transplanted. Of course, they were all transplanted. So they had data on their livers, and what they found was that not all of them improved. So especially if you looked at fibrosis stage, a fair number either improved or did not change, but some of them actually got worse. Now, I asked them if they did morphometry on these biopsies, and they said no, but it makes you concerned that you can't just use FibroScan to make this decision. There was another abstract at the meeting that said, well, if you've got a FibroScan less than 7, your incidence per 100 is 0.38. The cutoff is 1.5 for HCC screening, so you don't have to do HCC screening in these patients. And if your cutoff was higher than 20, then of course you did. But there have been 4 publications in the last year that are addressing this, and some of them are suggesting that you don't have to stop screening. So we were asked to render an opinion about this, and this editorial just came out in CID, and we said don't stop screening, because the paper we were addressing said that if you had a liver stiffness less than 14, there was nobody that developed liver cancer, but they only followed a limited number of patients for 2.5 years, and our concern is that you're going to develop liver cancers later on, number one, and number two, that the cutoff that we use for Hep C is not correct for this group of patients. So you remember the cutoff for Hep C is if you have an incidence of cancer less than 1.5% per year, it's not cost-effective to screen. And that's because patients with Hep C have cirrhosis, liver cancer, all kinds of problems, and they die. But the cutoff for Hep B is 0.2%, because Hep B patients get treated with nukes and they do not die. So we think this group is more like Hep B now, because they're not going to die from their liver disease. We're not transplanting patients from decompensated Hep C anymore. That's over. We're only transplanting them for liver cancer. So we think the cutoff of cost effectiveness needs to be changed, and we think there may be other factors that will predict who reverses. Like, for instance, if you drink, you're not going to reverse. If you're obese, you're not going to reverse. And not everybody in that registry that Ira presented, only half the people reversed. So we don't think it's quite ready for prime time. So I'll take the last couple minutes. I'm going to give you a lot of time, Bob, and talk about the simplified updates. So this is one page. It's one page in the guideline document, and I told our advanced endoscopy guys and our group that even an advanced endoscopy guy could do this, I thought, possibly. So it says, if you're eligible for simplified treatment, if you don't have cirrhosis, you're not treated before, this is all you need to do. You need to make some assessment of fibrosis. We're using one of these non-invasive techniques. We use FibroScan, but you don't have to. You have to look for DDI assessment, and we all have apps that'll do this for us now. You talk to the patient, tell them not to drink, tell them to stay on the drug. You do baseline tests, and notice they only ask for hepatitis B surface antigen, so they dropped hepatitis B core antibody out of the analysis now. You don't have to do a hepatitis B core antibody, so it turns out the FDA had that wrong. Not a surprise, because these people are not getting reactivation, but only the surface antigen positive ones are. You have to do a quantitative HCV RNA to prove they have hepatitis C, of course, and a pregnancy test if they're of childbearing age. They don't qualify for this if they've been treated before, they have cirrhosis or transplant, they have end-stage renal disease. There's 2 regimens, 8 weeks of GP or Mavorite or 12 weeks of Sofvel Epclusa. Pretty straightforward. On-treatment monitoring, pretty simple also. If they're diabetic, keep an eye on their labs. If they're on warfarin, keep an eye on their labs. You do not have to do HCV RNA during therapy. You do it 12 weeks after you're done. Follow up after you're done. It's important to document an SVR. I've had a few patients elope after they're treated, where they just get the drug, they take it for 8 weeks and they're done, they split. And then I see them back like 4 years later, and I go like, hey, where'd you go? And they say, well, you treated me, I'm done. And I go, yeah, but you never got an HCV RNA at the end. So we never proved you were treated successfully. So most of the time they are. So the patients are just assuming that now. So try to get them back. So the other new stuff on the guideline document that just came out last month is said that everybody should have a one-time routine opt-out testing for all adults. So we don't do that, but this is what has been recommended because they don't, just like we do for Hep B. Soft-Vel has now been approved for end-stage renal disease, and kidney transplant patients or patients on dialysis can receive Soft-Vel, so that's new. That's on their label. There's a few other things that are on the label. Children I mentioned already. So the recent updates to the label I'll talk about for a minute. So this is the renal impairment for Soft-Vel. So that now says you can give Soft-Vel to any patient regardless of their degree of renal impairment. 8 weeks for compensated cirrhosis is fine. However, before that, there was a warning from the FDA that compensated cirrhotics that were not Child's B or C who received PI-containing regimens could decompensate. And this was of concern. It happened with Zepatier, it happened with Mavyret, it happened with Vosevi. They all contain PIs. Mavyret, of course, was the most widely prescribed, so they had the most cases. But they didn't describe the cases. These came out of a MedWatch report from the FDA, so they were very messy. At the AASLD, they did actually describe the cases, and it looked like most of them were drinking or had decompensated cirrhosis to begin with. So, somebody with ascites that then got put on diuretics that shows up at your office, you consider them a compensated cirrhotic, and they're actually not. They're actually they've actually sort of borderline. So how do you handle that? This is my 2 cents that I just released in GastroHep. It's not in the guideline document. It will be in up-to-date because only Adrian DiBichele has to agree with me for it to be in up-to-date. But the guideline committee will decide what they do. I said if you've got low platelets or a FibroScan over 20, I would endoscope the patient. And if they have varices, I would choose not to use a PI-containing regimen. I just use Soft-Vel because they're borderline. So they're sort of borderline compensated. So you don't have a lot of patients like this, but if you have somebody, just be careful with them. That's the issue. And if they're drinking, don't, I tell them to stop drinking while they're getting treated. So that's my 2 cents. So in summary, it's feasible to treat PWIDs, but they have to be adherent. We have pan-genotypic regimens available for children, and we have a short course that's pan-genotypic for compensated cirrhosis. Be careful with your compensated cirrhotics. I think there is a benefit of SVR both for liver-related mortality and other mortalities, and I think this will come out in the next Cochrane analysis. Preemptive therapy if you're going to use a positive donor, and don't stop screening HCC after SVR. Thank you very much.